Thanks, Krish, and Mark and Frank, thanks very much for the invitation to present today. It's a real pleasure to be here. So I'm going to talk to you about our enhanced recovery pathways and a little bit then at the end about some novel pain control methods that we've been utilizing. So I need to disclose that I am a consultant for Olympus. I teach EBUS courses for them, and I'm also a consultant for Pacira Pharmaceuticals. That's important because they make Exparel, and I'm going to be talking about Exparel. So what is enhanced recovery? Well, the Enhanced Recovery After Surgery Society defines it as a multimodal perioperative strategy that's designed to enhance early recovery for patients undergoing major thoracic surgery. It was really promulgated in the 90s by that guy, Henrik Kellert, who's a general surgeon from Copenhagen. And his idea was that if you took evidence-based interventions that were each designed to reduce some part of the stress of surgery, that outcomes would ultimately be better. So as you know, with surgery, the initial tissue injury, we were bombarded with a bunch of cytokines, inflammatory agents, immune modulators, et cetera. And this causes a lot of dysfunction for the patient: pain, increased catabolism, nausea, vomiting, immune deregulation, and coagulation cascades, et cetera. So the concept is if you can do things that reduce that surgical stress, that you may have better outcomes. And there are sort of 4 pillars that Kellett describes to accomplish this. And the first and probably the most important one, to be honest with you, is a minimally invasive surgery. So VATS, lobectomies, robotic esophagectomies, whatever. But also in terms of limiting the extent of one's surgeries as well, right? Getting drains out earlier, limiting the number of chest tubes that we put in after cases. All of these things cite inflammation, so less is sometimes more. And then we have various pharmacological interventions. A cornerstone to enhance recovery is this non-opioid multimodal anesthetic regimen. Okay, so opioids have a lot of side effects, negative effects, nausea, vomiting. We're all familiar with them, respiratory depression, et cetera. But things like glucocorticoids have been shown to reduce inflammation after surgery. They're antiemetic. Beta blockade, membrane stabilizers like statins, all have been shown to help reduce the stress related to surgery. Excellent pain control, regional neural blockade. The mainstay, of course, in our practice has traditionally been epidural, but there are some other alternatives which we'll discuss. And then what I like to call preserving the status quo. So keeping the patient normothermic, keeping the patient euvolemic during and after surgery, maintaining mobility, early return to nutrition, et cetera. There have been numerous randomized controlled trials over the last decade, mainly in the general surgery, colorectal field, and orthopedic field, but there have been a few in the thoracic space. Essentially, all of these have shown in meta-analysis a reduction in overall perioperative morbidity and a reduction in length of stay without an increase in readmission rates to hospital, which is important nowadays. This is not necessarily all that new, I know, to this audience, but as far back as 1997, I think it was, the Mass General group showed that by implementing a well-defined standardized pain or postoperative care pathway for lobectomy patients, that hospital stay could be reduced from 10 days down to 8. Subsequently, the Johns Hopkins group reduced that from 8 to 6 days, and then Cerf upped the ante with 500 patients published in 2001, where he showed a length of stay of only 4 days by employing methodologies such as epidurals for everyone, no ICU stay, early ambulation, discharge with chest tubes, et cetera. And then incorporating minimally invasive surgery then into this strategy. Of course, Rob McKenna showed that one could even improve outcomes and reduce length of stay to only 3 days. But it's not just about length of stay and cost containment, of course. I mean, what we're interested in is functional recovery of the patient. And so this is the real concept behind enhanced recovery, that with a traditional pathway of care, the surgery results in a debilitation period with slow recuperation over some weeks before patients can return to their intended oncologic therapy, perhaps. The idea of enhanced recovery is that perhaps the surgical insult is initially less. Even if it isn't less, the downstream effects of that surgery may be modulated, such as recovery is enabled and return to intended oncologic therapy is enhanced. And I think, working in a cancer center, this is also of importance, that when you think of it, the healing environment in a surgical wound is the perfect environment also for tumor growth. And we know that, that surgical wounds, there's a pro-angiogenic environment. Potentially there's release of tumor cells into not only into the locality, but also into the systemic circulation. Surgery itself is immunosuppressive, as are volatile inhalational anesthetics, opioids, and then the numerous inflammatory factors that are released at the time of surgery potentially, at least, can facilitate tumor growth. And this is a recent laboratory study published a couple of years ago that showed that lung cancer cells actually have these little receptors on them called mu receptors, and that if you played out lung cancer cells and you add opioids to them, those lung cancer cells actually grow and they migrate, and they also can have this epithelial to mesenchymal transition, a hallmark of the metastatic state. But there's other reasons, of course, why we want to limit opioids. We have a huge problem in this country. 15,000 patients die per year because of overdose of prescription narcotics. 1 in 15 patients who I prescribe a narcotic to for post-surgical pain is going to be on those narcotics 150 days after surgery. And this is a huge economic burden as well. Over $72 billion are spent each year on the treatment of patients from misuse of prescribed opioids. And ultimately, we're accountable for patients who die because of these. So what are the evidence-based enhanced recovery initiatives that we do at our institution currently? This is the first one, patient education. When we meet with the patient in the clinic, we tell them what the expectations are. It's like having kids going out to dinner. You tell them what you expect from them in advance, and they're much more likely to comply. So we talk to them about the fact that they probably will be going home within 2 days. They probably are not going to be getting narcotics. They're potentially maybe going home with a chest tube. When day 2 comes around and you tell the patient that they may be leaving, they're a lot more accepting of it. Preoperative fasting. We don't fluid restrict patients anymore. And there's good reason for this. There's numerous randomized studies that have shown no link between perioperative taking of clear liquids and an increasing risk of aspiration. The data just isn't there. In fact, the American Society of Anesthesiologists states that in their guidelines that clear liquids are permissible, in fact, even advised up to 2 hours before surgery. Now, my bet is, like at our institution, that most of your anesthesiologists are sticking to either the 6 or 8 hour rule and are fasting patients before from midnight the night before. So we don't do that anymore, and that's better. So patients don't come in dried out. They're a lot more euvolemic at the time of their surgery. Dawn touched on this as well. Gabapentinoids, especially in meta-analyses of multiple randomized studies, have been shown when given preoperatively as a preventive strategy, decrease the amount of postoperative pain. So we administer gabapentin 300 milligrams routinely to patients in the holding area, as well as an extended release tramadol. Dexamethasone steroids have been shown conceptually, at least they reduce inflammation, right? But they have also been shown in randomized studies to reduce not only postoperative pain, but also postoperative nausea and vomiting. Opioid sparing strategies. It is now very common for us to perform a thoracotomy or a minimally invasive lobectomy with the amounts of opioids that a colonoscopist would use for your screening colonoscopy. 100, 150 mics of fentanyl. And we're able to accomplish this because we're giving adjuncts such as acetaminophen IV at the time of induction. We're running ketorolac intravenously during the case. We're not noticing any increased bleeding or anything like that. Our transfusion rates have not gone up, nor has our postoperative creatinines bumped. And these 2 drugs together provide fantastic pain control after surgery. We no longer, or I wouldn't say we no longer, but we limit the use of inhalational anesthetics, and those that we do use are the short-acting ones. We prefer intravenous anesthesia using propofol. Propofol has anti-inflammatory effects as well. It's been shown in randomized studies also to benefit in terms of postoperative nausea and vomiting. Goal-directed therapy. So currently we're monitoring intraoperatively. We're not just empirically sort of making decisions based on heart rate and blood pressure, et cetera. We're actually monitoring the stroke volume variation, which is a lot more sensitive method of determining how much fluid you give a patient. So you want the patient here, you don't want them hypovolemic, you don't want them hypervolemic either. And it's very often that we'll use non-invasive monitoring. A lot of our patients for thoracotomy for lung cancer resections don't even get A-lines now. Some form of regional analgesia. We've been using epidurals up until the last 4 or 5 years. We transitioned now to more local blocking techniques, which we'll get into, but some form of regional anesthesia is important. We all know this, and we've been doing this for years. Early ambulation, highly important. I think one of the big things about getting patients out of the ICU is that they start walking, and that helps recovery. And then minimization of drains. You know, when I started in 2001, I was putting in 32 French chest tubes, 2 of them in every thoracotomy patient I did. Now I'm usually putting in 1 28 French or sometimes even a 24 French chest tube. Early removal of Foley catheters, we take them out first post-op day now. In fact, we're planning on, for routine lobectomies, not even putting a Foley in at all. So these type of things are what we're doing currently right now in our practice. But I want to put it in perspective for you and sort of show you the evolution over a period of time, and then look at some outcomes as well. So over the last 10 years, even before that, back in the late 90s, we were not routinely putting our lung cancer patients after resection in the ICU. They would go to a monitored floor. So it's extremely rare now that a patient for lung cancer, even extrapleural pneumonectomies, we put on a monitored floor now at this point. Mid-2005, we started our first, our minimally invasive program, our first VATS lobectomy, followed shortly thereafter by our minimally invasive esophagectomy program. 2008, we did the same thing we did for lungs in the 90s with esophagus. We took them out of the ICU and put them on the floor. They did much better. Our robotic thoracic program started in 2011. Liposomal bupivacaine became available at our institution in late 2012. And then we really began our enhanced recovery initiative in 2014, and full implementation was in September of last year. And we'll talk a little bit about some data related to that. This just shows some case volume over the last 10 years, sort of a plateau, about 1,000 cases a year or so. We've noticed over that period of time a statistically significant reduction in overall 90-day mortality, decrease in any postoperative events, pretty significant decreases in atrial arrhythmias, ICU readmissions. Started at about 100% utilization of epidurals. We're down to about 40% currently, and probably even lower. This is for lung cancer, sorry, and esophageal cancer over here, and total over here. Length of stay has similarly declined over the last decade, and what has increased is our penetrance of our use of minimally invasive surgical techniques. So just regarding lung cancer resections and minimally invasive techniques, just a brief overview of our results. Like everybody else in this audience has shown, reduction in length of stay, reduced transfusion, reduced pulmonary morbidity, atrial arrhythmias, and overall morbidity, almost 50% reduction. When we looked at a large population of our patients over a 10-year period, we found that VATS was a significant, an independent predictor of improved survival. And although on matched comparisons this didn't reach significance, certainly there was a trend. And in terms of functional recovery, pain, fatigue, return to work, et cetera, VATS did significantly better than open, again, what many other people have also shown. In 2008, we stopped ICU admission for our esophagectomy patients. We just published this last year. So prior to this, they were often kept intubated. We extubated them in the operating room, put them on a telemetry floor, didn't put them in the ICU, got them up and walking the day of surgery or even the night of surgery sometimes. Started J-tubes on day 3 and instead of waiting for bowel function to return. We're a lot smarter about our Foley management, got them out at day 3 if the patients were stable, NG tube removed on day 5 instead of day 8. There's probably still some further modifications we can do here to even enhance that better. But nonetheless, you can see that as of 2008, ICU admissions, direct admissions to the ICU dropped substantially. That's the gray bar. And then length of stay also declined over that period of time. So it went from 12 days to 8 days. And importantly, pulmonary complications were significantly reduced, less reintubation and decreased atrial arrhythmia. So literally just by getting patients out of the ICU, getting them up, walking around, and being a little bit smarter with what we were doing with their drains, no fancy drugs, nothing else, we significantly shortened their hospital stay and saved the institution quite a bit of money. So I'm going to turn now briefly to pain management. And the whole idea about pain management for enhanced recovery is really a multimodal analgesic approach. So you bombard the pain from multiple different lines of attack, essentially. So we have regional, systemic, and then adjunctive pain modalities. The regional ones, as you all know, are the thoracic epidurals, which have been our mainstay, but now we're concentrating on can we block these afferent pain signals before they even get to the spinal cord. And we'll talk a little bit in more detail about liposomal bupivacaine for that, but I think on-cue pumps work very well for that. Paravertebral blocks work well for that as well. Systemic pain control probably still is largely dependent on opioids, but we are trying to shift away from that now and concentrate more on non-steroidal anti-inflammatories, COX-2 inhibitors, and acetaminophen. And then you've got these adjunctive modalities such as clonidine, the alpha antagonists, GABA inhibitors, et cetera, that sort of modulate the signals between the spinal cord and the brain. So in 2012, we got liposomal bupivacaine approved at our institution. We were trying to experiment ways that we could use this, and came across this study from over 35 years ago, something called a posterior intercostal nerve block. This is lateral to where a standard paravertebral block would be performed, which is usually at about 2.5 centimeters off the midline. Nunn and Slavin showed that if you went about 5 to 7 centimeters off the midline, that you got nice tracking of the fluid into the paravertebral space, but also cephalad and caudad. So here's where a standard paravertebral block would be performed, and this is sort of the area where we do our block. This is done under, generally we do under thoracoscopic visualization. I don't think you have to, but this is a little bit more accurate because you can avoid puncturing the pleural membrane. We've put in, we're injecting liposomal bupivacaine in this instance, and I just added a little bit of methylene blue, which I don't usually do, but this is for the purposes of the video. But you can see you can be very accurate with the injection. We inject usually about 3 or 4 cc's of a 1-to-1 dilution of the product, and it tracks beautifully all the way down to the paravertebral area. So at the end of the case, you sort of see that you've got this nice sort of 5-level block that extends to the paravertebral space. Our initial look at our initial patients that we did this on, we had 54 patients that we'd done this type of block on. We published this last year. We did a case-controlled match to patients who'd had thoracic epidural analgesia, and importantly saw no difference in complications, especially no difference in supraventricular or ventricular arrhythmias. Obviously, QT prolongation would be a concern with bupivacaine, and there was no difference in neurologic complications either, so no seizures in either group. But what was significant was that there was a little bit shorter length of stay in the liposomal bupivacaine group. Importantly, no differences in mean pain scores, maximum pain scores, or opioid requirements between the two groups. However, when we broke it down into the groups of patients that had minimally invasive surgery versus thoracotomy, we could see no difference in the minimally invasive group. The patients who had thoracotomy, in orange is shown the liposomal bupivacaine, they had less opiate requirements and lower pain scores than the group of patients who had epidural. So this was very interesting to us and sort of led us to further use this technique. One of the ways that we're able to do this, as I said, is by the administration of other adjunctive non-narcotic agents. So we're using typically acetaminophen, we're using Toradol, we're using gabapentin, et cetera. And you can see that in the group of patients who had liposomal bupivacaine, more than 80% of them had the use of at least 3 of these adjunctive agents. This is just a case that we did, a guy who needed a sleeve lobectomy, not my smallest incision, I will argue. And we did a block. This was his postoperative pain regimen, and I show you this because this is fairly typical. So he had a PCA put in at the time of surgery, but pushed the button twice. He had a tiny dose of hydromorphone after the PACU, but the rest of his pain management was entirely based on ketorolac, acetaminophen, and a little tramadol. So since 2015 of last year, we have implemented an enhanced surgical recovery program that has involved our surgeons, full buy-in, so everybody's doing it the same way. It's involved our anesthesiologists, so they're all doing what they need to be doing intraoperatively. And this is a quality improvement study. I'm going to show you the results of this. Is not peer-reviewed yet, these data, but I think they're interesting. So we had 123 patients managed on this enhanced pathway, so they all got the pre-op meds. They all got the intraoperative things, dexamethasone, et cetera. Most of them had intravenous analgesia, or anesthesia. We excluded confounding things like chest wall resections, et cetera. They all had these paravertebral, or these posterior intercostal nerve blocks, and we compared them then to a group of patients of about N of about 1,000 from 2012 to the end of 2015. No differences in overall demographics. For some reason, the group that had the enhanced recovery had less hypertension. I'm not sure why. This is the breakdown of those 123 patients. About 40% of patients were treated with a minimally invasive approach. Of these, about a quarter had a robotic approach. Primary lung cancer was the main indication. We did the extent of lung resection, so sleeve, pneumonectomy, whatever, lobectomy. We found that pulmonary events were less, shorter hospital stay, and fewer patients were being discharged with chest drains. This didn't reach significance, but it'll be interesting to sort of follow this a little bit more closely, that 90-day mortality was 2.4% in the conventional arm and only 0.8% in the enhanced recovery arm. Let's talk about opioid use, and then I'll finish. So this graph shows the percentage of patients on any given given postoperative day requiring opioids, and you can see it varies between 30 to 40%. This is for VATS. The average morphine equivalents per use, you can see VATS takes a little bit less. And this is the important slide, that 40% of patients required no opioids after their PACU release. So once they got on the floor, 40% of patients did not require opioids. 60% had minimal opioid use, so 2 or fewer individual doses of a narcotic. The vast majority of patients did not require PCA, and about 60% of patients or so were discharged home without any narcotics. They did require these other adjunct analgesics on discharge. Most of them had 3, most of them had 4, some had 3. So in conclusion, I'd say that enhanced recovery surgical programs are feasible in thoracic surgery, but they really require the close collaboration and buy-in of anesthesiologists, pharmacists, your mid-levels, and especially the patients. They appear, at least their early data suggests that they appear to result in better outcomes perioperatively. The impact on cancer survival is unknown, but worth consideration and certainly study in the future. And then I think that novel methods of regional blockade, at least in our practice, appear to reduce the overall use of opioid consumption. So with that, I'll leave it. Thank you very much.